Good evening, I'm Dr. Bennouar Salam, an assistant lecturer in clinical biochemistry from the University Hospital Center of Blida in Algeria. And today I'll be presenting the experience of our laboratory in the establishment and the validation of the risk score for the early prediction of COVID-19 severity. COVID-19 disease is an infectious pathology characterized by an unprecedented rate of emergence. Since the first case reported in Wuhan province in China almost 12 months ago, the disease has spread swiftly to affect more than 2,000 countries in all continents around the world. In Algeria, the first confirmed case of COVID-19 was declared on February 25th of 2020. Soon thereafter, a contagion area was formed in the Blida region, which became then the epicenter of the outbreak. After a steady state observed from the beginning of last September, an alarming upsurge was reported from the end of this October, raising the total contamination count to more than 62,300 cases and the total mortality rate of more than 2,000, as reported by the latest public reports. The clinical manifestations of COVID-19 is known for its very heterogeneous aspect, while in most cases the disease remains silent or is restricted to a few mild respiratory symptoms. For certain individuals, this disease may progress to severe or even critical forms, requiring specific management in intensive care units. The seriousness of severe forms is related to the particularly high rate of short-term mortality. Indeed, according to recent epidemiological investigations, the mortality rate is esteemed to be 20-fold higher in patients who acquire severe forms of the disease. Facing this pandemic, the greatest challenge confronting clinicians is to avoid progression to severe forms. It is therefore crucial to dispose of an early risk stratification system. This system will allow identifying high-risk patients at an early stage, optimizing their management and overcoming the shortage of medical and material resources, particularly often encountered in such emergency situations. In a recently published work, we have identified, in addition to advanced age, 6 biological abnormalities that could serve as early risk markers, and these include elevated blood urea nitrogen, elevated C-reactive protein, decreased natremia, decreased albuminemia, elevated lactate dehydrogenase, and elevated neutrophil to lymphocyte ratio. For clinical convenience, the present study was designed with the aim to construct from these factors a scoring system that would allow the screening of high-risk subjects upon their admission, to validate this score in a separate cohort, and also to assess its relevance in predicting short-term mortality. Materials and methods. This is a single-center retrospective cohort study including COVID-19 infected subjects who were admitted to the Franz Fanon unit of the University Hospital Center of Blida in Algeria. The study population, design, and site will be detailed later on. Briefly, upon the onset of the outbreak in the Blida area last March, 3 isolation wards as well as an intensive care unit were set up in the hospital to handle the confirmed cases of COVID-19. So, after excluding subjects under the age of 18, pregnant women, cases of active cancers, and patients who died within 48 hours after admission, a total of 329 subjects admitted between March 27th and April 22nd of 2020 were enrolled and followed up for up to 28 days. This group represents the risk score establishment cohort in the present study. All included patients were tested upon admission for the following biological parameters. Inflammatory markers, including CRP and a total blood count with the calculation of the NLR ratio. blood glucose and renal function markers, including blood urea nitrogen, serum creatinine, and electrolytes, sodium and potassium, albumin and total protein, hepatic enzymes, LDH, glutamoxaloacetic transaminase, and glutamopyruvic transaminase, gamma-glutamyl transpeptidase, and alkaline phosphatase. The final endpoint was the progression to a severe form as defined by the requirements for mechanical ventilation, admission to ICU, or death. In the previous study, baseline biological parameters as measured at admission were integrated into a proportional Cox regression model in order to identify among them those that could serve as early predictors of disease progression. As a result of this study, age above 60 years, in addition to 6 biological conditions, were selected as potential risk markers independently related to COVID-19 severity. These were elevated blood urea nitrogen, elevated LDH, elevated NLR, and elevated CRP, as well as decreased albumin and decreased natremia. These 7 factors were then combined into an ordinal risk score consisting of 7 consecutive levels, S0 to S7. The significance of the association between the risk level as assigned upon admission and the occurrence of severe forms was first assessed in the establishment cohort, and then in a separated validation cohort composed of 2,047 additional confirmed COVID-19 cases who were admitted to the same hospital between April 25th and June 20th of 2020. The same exclusion criteria were also applied when enrolling in the validation cohort. In the second stage, the ability of this score to predict in-hospital mortality was tested in both cohorts separately. The statistical analysis was performed using SPSS software version 2.5.0. The Shapiro-Wilk test was used to explore continuous variable distribution. The continuous variables are presented as means, plus minus standard deviations or medians, and are compared using the student t-test, Mann-Whitney U-test, or ANOVA, depending on the normality of the distribution and the number of subgroups to be compared. Qualitative variables are outlined as percentages and are compared using Pearson's chi-square test for trend. For the purpose of assessing the predictive performance of the established score in the early prediction of worsening outcomes as well as the prediction of in-hospital mortality, the area under the receiver operating characteristic curve, known as the AUC, and its 95% confidence interval were calculated. Cutoff values were defined using the Uden index. The maximum value reflects the best balance between sensitivity and specificity. For all statistical tests, a p-value of less than 0.05 was considered as statistically significant. For the results, a total of 576 patients were enrolled in this study, of which 329 patients were part of the establishment cohorts and 2,047 were part of the validation cohort. The baseline characteristics of the study population are presented in tables 1 and 2. A clear predominance of both male gender and age group above 60 years was noted in each cohort, without any significant differences. Over the follow-up period, 43.5% of patients in the establishment cohort had progressed towards severe form requiring intensive care. In the validation cohort, this proportion was 34%. Moreover, the validation cohort exhibited a higher mortality rate, 26.7 versus 13.4%, and a lower average survival duration, 2.8 versus 25 days. From a biological standpoint, the two groups were broadly comparable. However, the validation cohort showed a higher level of blood urea nitrogen, white blood cells, neutrophils, and NLR, as well as lower albumin, protein, and lymphocyte levels. For each patient, the risk score was calculated by the sum of points assigned to each of the included variables. 7 risk levels were thus defined: the incidence of severe forms and the mortality rate by risk level as shown in figures 1 and 2 respectively. In the establishment cohort, the lowest severe forms incidences were observed in both score levels S0 and S1, 2.5% in the S0 level and 3.3% in the S1 level. Then, this incidence increased gradually and significantly across the score levels. Interestingly, it was observed that all patients classified in both score levels S6 and S7 had acquired a severe form. A similar trend was noted in the validation cohort, whereas no severe form was reported in patients assigned to to the level S0. All patients classified at level 7 had progressed to a severe form. With regard to the mortality rate, according to the risk level, a linear bilinear association was also found in both the establishment and validation cohorts, with no fatalities reported in the S0 level of the establishment cohort, nor in the S0 and S1 levels of the validation cohort. The highest mortality rate, meanwhile, was reported among patients who were admitted with the level S7 of the risk score in both the establishment cohort with 66.7% and the validation one with 100%. Similarly, in each cohort, the average survival duration tended to decrease gradually with increase in risk score levels. The ROC curve was used to explore the effectiveness of the risk score in predicting both severity and mortality. In the established cohort, the score showed a very satisfying ability for the early prediction of birth severity, area under curve of 0.95, and mortality, AUC of 0.84. For a threshold value of 3 and higher, the score could predict severity with a sensitivity of 95% and specificity of 85%. Similarly, for a threshold value of 4 and higher, the score could predict mortality with a sensitivity of 86% and specificity of 71%. Likewise, in the validation cohort, the score showed the predictive performance as satisfying as what was observed in the establishment cohort, AUC of 0.74 and 0.90 for severity and mortality respectively. For the same above-mentioned cutoffs, the score presented a sensitivity of 82 and 91% and a specificity of 71 and 70%, respectively, for severity and mortality. So in this retrospective study, we developed and validated a risk score which, with satisfying performance, was able to predict not only progression to the severe form, but also short-term mortality caused by COVID-19. This ordinal score, to be calculated as early as the admission stage, will enable ranking patients into 7 consecutive risk levels and could thus contribute to the more targeted management of higher risk cases, particularly in low-resource areas. This score is built up, besides age, from 6 biological factors widely available in current practice, easy to assess and quite affordable. These are CRP, NLR, urea, natremia, albuminemia, and LDH. Some of these parameters had already proven their individual effectiveness in predicting COVID-19 severity in numerous previously published studies. Among the recently published studies on this topic, the study conducted by Galloway et al. Led to the establishment of a clinical biological score based on the following parameters: advanced age, male gender, comorbidities, respiratory rate, oxygenation, radiographic features, neutrophils, elevated CRP, and reduced albuminemia. In this study, the authors reported that the threshold value of 4 was associated with a higher cumulative incidence of critical forms and 28 days mortality. In another study conducted by Gong et al., a nomogram based on biological parameters was constructed to predict at an early stage the progression of COVID-19. In this study, the authors found a significant correlation between the clinical severity and elevated LDH, urea, CRP, direct bilirubin, red blood cell distribution with coefficient variation, as well as the decreased albumin levels. In most available studies, the increase in inflammatory markers was a constant sign related to COVID-19 severity. Besides CRP, NLR is particularly interesting inflammatory marker for monitoring COVID-19 progression, as it indicates both a decrease in lymphocyte count, a direct consequence of viral aggression, and an increase in neutrophil count, an indicator of exacerbated inflammatory reaction and bacterial superinfection. In addition to the inflammatory parameters, the concomitant decrease in albuminemia and natremia, as well as the elevation of cellular damage-related markers as the LDH and urea, are further indicators of the extent of the inflammatory response and thus of the disease's severity. Their prognostic value in hospital settings was discussed well before the COVID-19 pandemic. The results of this study should be viewed considering a number of limitations. Firstly, this is a retrospective study including patients who were admitted to a single COVID-19 center. This may limit the generalizability of the findings to other populations. Secondly, the score established is based solely on biological parameters. The inclusion of other clinical and radiological features could contribute to the development of a new score with improved predictive capability. Finally, and despite a satisfactory follow-up period, most of the patients included were still hospitalized at the end of this study, so their status could change further. So further studies with a longer follow-up period and larger sample size are needed to understand the impact of this score on survival beyond 28 days. As a conclusion, this study provides a useful risk score based on biological routine parameters assessed at the time of admission, which has proven its effectiveness in predicting both severity and short-term mortality of COVID-19. At the end, and on the behalf of all the authors, I'd like to acknowledge and thank all the staff of the laboratory and the clinicians and staff of intensive care unit for their considerable and courageous efforts in the fight against the current tragic clinical and social emergency of COVID-19. And I would like to mention that the authors have no conflicts of interest to declare, and this research did not receive any specific grants from funding agencies in the public, commercial, or non-for-profit sectors. And thank you.